next paper is by Dr. Prabhu Bhaskaran. He's going to present comparison between ILM peeling versus inverted flap for large macular holes.
Good afternoon, one and all. This is a randomized control trial comparing the outcomes between conventional ILM peeling versus perfluorocarbon liquid assisted inverted flap surgery in large macular hole. So it's a known fact that the closure rate in conventional ILM peeling surgery in large macular hole is less, 50 to 80% compared to smaller medium-sized holes. That's why inverted flap surgery was suggested by Michael Swa in the year 2010 to increase the success rate. But there are certain things that we need to look at. The short-term, results of this inverted flap is well studied, but in literature, the long-term effects is largely lacking. Also, as it was categorically mentioned by Michael Zua in its original paper, the flap dislodgement rate was 14%, which was more, and that's a kind of rate limiting step in determining the success of this procedure. That's how Park et al. Later in subsequent years he suggested the role of PFO to achieve better success rate, but there is no RCT till date to prove if PFO assisted surgery is really beneficial or not. Also, there is additional ambiguity in in this segment. We don't know exactly the difference between ELM and EZ recovery rate between these techniques, and also the time taken for this flap to disintegrate with the surrounding structures. With this background, we thought of conducting a RCT between these two techniques. So our purpose was to analyze the outcomes following conventional ILM peeling versus perfluorocarbon liquid assisted in inverted flap technique in large macular hole. So this is a prospective double-blinded RCT conducted, approved by our institutional ethics committee, conducted at our institute and registered with CTRI India. So we conducted the study between Jan 2018 and December 2020. So we included patients who had large idiopathic macular hole with aperture size of the minimal hole diameter more than 500, and we excluded patients if the hole size was less than 500, also secondary to other etiologists or coexisting ocular pathologists or monocular patients and pediatric subjects, etc. And apart from the routine baseline evaluation, all patients underwent the OCT procedure in Heidelberg. We specifically looked at the minimum diameter, maximum diameter, and the height of the macular hole. So we used Microsoft Excel automated sampling to randomize these patients. We gave two codes, surgical code. One patient would undergo conventional surgery, and two inverted flap surgery will be done. These codes were opened just before commencing the surgery and opened up to the surgeons. So as far as the surgical technique are concerned, we selected three Vitreo Retinal fellowship trained senior surgeons with experience more than 5 years. Technique number one, conventional surgery. It's a standard 25 gauge surgery. We used Brilliant Blue G dyed 0.2 ml, manufactured by Aurolab India. The ILM, the initial flap was raised either using finesse loop or pinch and peel technique and extended around 2 disc diameters around the macular hole, and either a short acting or a long acting gas was used according to surgeon's discretion at the end of surgery. And this is inverted flap technique. Here the steps are the same except for the fact that a small flap of ILM was retained around the edge of the hole, and the size of which was trimmed using cutter at the rate of 1000. We preferred 1000 cut rate per minute, and with a suction of 50 millimeters of mercury. And as you can see here, I'm trimming the flap, and we used a PFO bubble, small bubble, and stabilize the flap inside that, and we used a flute to aspirate the saline completely, and before we approach the PFO bubble, and then we approach the PFO bubble so that there is no saline to displace the flap, and FAE is done meticulously at the end of the surgery. So the sample size was kept at 99 eyes with a to prove a superiority limit of 10% between the two techniques, and the level of significance was set at 5%. So outcome measures, we looked at these are the outcome measures. Primary outcome measure was the difference between the closure rate between the techniques, and secondary outcome we looked at mean BCVA between the techniques, and also we looked at recovery rate of ELM external limiting membrane and EZ ellipsoid zone layers between the groups, and also we looked at closure rate between the techniques using different gas tamponates, and we also looked at rate at which the time taken for the ILM flap to disintegrate completely in the inverted flap group, and we also looked at the difference between subfoveal thickness between the groups in closed macula holes. The primary study endpoint was kept at 3 months, and the secondary, we had two secondary endpoints at 6 and 12 months. So we followed up these patients till 1 year. So post-operative, patients were examined at 1, 3, 6, 9, and 12 months. Apart from the routine examination, OCT was done primarily to look at the hole closure, of course, and the type of closure, and the restoration of ELM, EZ layers, and the visibility of ILM flap, whether these blinded graders could see the ILM flap in inverted flap group or not, how long they could see. All of that we noted, and both intraoperative and postoperative complications were documented. So these are the definitions that we used in our study. If there was complete flattening of macular hole over the underlying RP, and if there was complete absorption of subretinal cuff, it's there is anatomical success or closure. And in addition to that, okay, sorry, I didn't go to the results. Can I get to, yeah, sure. So, so in our study, basically, we didn't find any statistical significant difference between the two techniques in terms of closure rate or visual outcome or the recovery rate of foveal structures. Interestingly we found that the subfoveal thickness was more in inflap group, which probably suggests that though the inverted flap group showed better closure rate, though it was not statistically significant, probably the increased subfoveal thickness, we are probably hindering the natural regeneration of subfoveal structures by putting excess flap into it. Probably in future studies we need to look at measures to gauge the ILM flap. Thereby we could achieve better results with this. Thank you. Yes.
Strange that actually we see that actually the inverse flap has better results, but you have thrown up that they are almost equal. There are only few papers which tell that. And in that actually you had 3 surgeons. Did you analyze surgeon-wise data of closure rate?
Not really, sir.